This group of drugs are the monoamine oxidase inhibitors. To introduce them, let's use a little bit of a story. Red Herring visits his favorite deli on Taylor Street. His weekly lunch is the Italian Delight sandwich, which is prosciutto, pepperoni, salami, mozzarella, fontanelli, which is a cheese, and topped with pancetta on a fresh baked roll. Recently placed on an MAOI inhibitor for panic disorder, he felt off and left work early due to a suspected illness. Okay, so in reality, he was experiencing some of the side effects that are associated with MAOI inhibitors. And so these drugs are great drugs. They work very well. It's the side effect profile that most patients can't tolerate. Okay, and so for monoamine oxidase inhibitors, the prototype here is phenelzine. There's a few others. And basically what they do is they inhibit the breakdown of catecholamines by inhibiting monoamine oxidase subtypes A or B, depending on which group of drugs they are. Typically, monoamine oxidase A breaks down serotonin and norepinephrine. Monoamine oxidase B, which we talked about in the Parkinson's lecture series, typically just breaks down dopamine. Okay, so there are drugs that are specific to one or the other or both. And so basically by inhibiting the catabolism of these neurotransmitters, we increase the concentration of either norepinephrine or serotonin, specifically in this particular lecture. These drugs form a covalent bond with the enzyme, and many are irreversible. And so you can see kind of a potency disparity in terms of how tight these drugs bind to the enzyme. There's a high first pass effect, meaning a large portion of the dose goes through the liver system and is lost to biotransformation. Okay, and so from a clinical standpoint, we can see kind of the same outcome because we're basically preserving the amount of norepinephrine or serotonin postsynaptically through a different molecular target. So back in the previous couple of slides, we looked at inhibiting SNRIs or SSRIs to basically inhibit the recycling of these neurotransmitters. Now we're working basically within the cytoplasm of these neurons to inhibit the catabolism. And so if you inhibit the catabolism of these neurotransmitters, you basically preserve their concentration and you increase their concentration postsynaptically. The side effect profile, however, is horrible. Nausea and vomiting, weight gain, hypotension, insomnia, serotonin syndrome if stopped abruptly, the tyramine effect, which I'll show you in a little bit more detail in a few slides, and some other rather unpleasant side effects as well. Who gets monoamine oxidase inhibitors? Well, patients that are refractory or unresponsive to all the drugs that we just talked about in this lecture. So once everything else has been basically eliminated for a variety of reasons, then these are the drugs that are left. And the reason that they're really kind of falling out of favor among patients is that they produce what's called the tyramine effect. And so these drugs have major dietary restrictions. Patients have to adhere to a very specialized diet because if they have some of these foods, this reaction right here called the tyramine effect, which is very specific to monoamine oxidase type A inhibitors, may manifest itself. Okay, and so let's just go through the tyramine effect. The graphical representation is shown here. I'll just go through these mechanisms right here. So it basically starts off with foods that are rich in rennet initiate the reaction. So rennet is basically an outcome of preservation. So those Italian lunch meats that I described in the little mini case or the mini story would all be rich in rennet. So salami, prosciutto, all of those kind of salted, dried, cured meats have a high degree of rennet. Also, pickled herring, some of the more European-style cheeses that are cured, as well as Chianti wine, wild game meats that are cured as well in this hemisphere would possibly fit into that basket. So these foods are rich in these curing agents, And basically, you get an influx of tyrosine. And tyrosine isn't that bad, but when you have a large component of tyrosine getting put into the system, it gets converted into tyramine, okay, which is a pressuramine, and can get really kind of broken down by monoamine oxidase type A, okay, which is normal part of the reaction. However, these patients are on inhibitors of monoamine oxidase type A. Okay, and so now when you inhibit the enzyme that is supposed to catabolize these compounds, now this tyramine can enter the circulation. Okay, and so it should have been degraded, it's not. Now it becomes incorporated into our neurons and it basically gets absorbed into the nerve terminal. What's problematic is that tyramine acts as a false neurotransmitter and it can cause a calcium independent release um, or reuptake inhibition, which can result in hypertensive crises and emergencies. Okay, there's another kind of pathway that's shown here where the tyramine can also have another step where it interacts with dopamine beta hydroxylase, and it can be converted into octopamine, which is another false neurotransmitter, and that can produce a hypotension. Um, that's typically not found in acute changes. You can see hypotension being brought on by more chronic changes over the long term. We typically see the hypertensive crisis on the monoamine oxidase inhibitors. Okay. So major dietary restrictions with these drugs. And so here's some of the other foods that these patients have to avoid. I touched on some of the cured cheeses and some of the European style meats, but also certain fruits and vegetables. Fava beans, for example. I don't know who in their right mind eats banana peels. I've never seen or heard of anybody eating a banana peel, but if you are on an MAOI inhibitor, you cannot eat a banana peel. Certain beverages, many of the tap beers or draft beers also can produce the tyramine effect, as well as several yeast or soy products as well. And so these are the foods that have to be avoided pretty much at all costs, and then these are the foods that would be allowed. And so many of these are alternatives to this middle column right here. So major food interactions, as well as major drug interactions. And so these are the drugs that patients with monoamine oxidase inhibitors must avoid. And if you've never come across these drug interactions, when the next time you're at the pharmacy, just grab a cough syrup or a nasal decongestant right off the aisle, and there's a little sticker on the bottom or a little graph that says, note, if you are on one of these drugs, or if you are taking one of these MAOI inhibitors, please do not take this medication because it can produce one of these hypertensive crises. And so this is clinically relevant and also quite problematic. But again, the number of patients that are on MAOI inhibitors has significantly dropped over the years. There are new indications coming out for these drugs, but it's, again, these drugs are not kind of the go-to main therapy because of these food and drug interactions. Speaking of drug interactions, I wanted to draw your attention to this combination therapy slide, which I put together. We haven't gone through obviously all of the drugs, and so you can, you'll probably see this slide again and again in various capacities. But remember, when you combine a monoamine oxidase inhibitor plus an SSRI, you can very quickly produce the serotonin syndrome. I think that that's probably specific to the last two cases that we've talked about. When you see mental status changes, that's a good indication that some of these drugs may be interacting with one another. When you start to see the production of autonomic instability, specifically tachycardia and hyperthermia, that's a good indication that some of these drugs are not working. And then, of course, there's neuromuscular components as well. Whenever we see hyperreflexia, cogwheel rigidity, we may be thinking of that serotonin syndrome. So for the drugs for panic, I think this is the most up-to-date ranking for these drugs. And I think, kind of your first line therapy, excuse me, are the SSRIs, followed by the SNRIs, if the patient's not responsive to the previous. And you kind of just go down the list. And then the benzo, if they exhibit partial response to SSRIs or SNRIs, and then you can see the implementation of mirtazapine, and then finally the monoamine oxidase inhibitor if nothing works to the above. I wanted to give you this slide. I was going to make this a session activity, but and I still might in some capacity, but I think this is really a great slide to kind of go through some of these drugs in terms of some of their side effects. And so we talk about a lot of overlap with all these different side effects. What I like about this is how to approach the side effect. And so up until now, we've just been kind of saying, well, what are they? But now, how do you approach them? And so this kind of gets more like advanced practice medical topics, but I want you to have this information. I didn't make a learning objective at this point. I'm not going to test you on it just yet, but I think it's good to have, good to review, and please email if you have any questions. Thank you.